is the assistant professor at the School of Respiratory Therapy at Taipei Medical University. And I already taught the ventilator this course in our department for about 6 years. Okay, and I think previous year I was a respiratory therapist working at Taiwan Hospital. Okay, so today I will talk about the fundamental parts of mechanical ventilation. And first part I will talk about non-invasive mechanical ventilation. And second part I will talk about invasive mechanical ventilation. Okay, so let's start from the first one. So because our topic is mechanical ventilator, so the first things we need to know is why do we need mechanical ventilation? Okay, so this is normal alveoli. I just simplified the alveoli over here, and this is normal people, so the ventilation is normal, and we usually use V to symbolize ventilation, and perfusion we usually use the Q to symbolize perfusion, the blood flow, pulmonary blood flow. So in normal people like us is normal V with normal Q, so this is called VQ matching. Okay. However, in some patients with some disease like obstructive disease cause partial obstruction of this airway. So this can decrease the ventilation, but the perfusion is still normal, right? So the ratio will decrease. So this is called VQ mismatching, or called low VQ. Okay, V is low, but Q is normal. So this can cause decreased saturation. So you measure the saturation from pulse oximeter, you will see the saturation decrease. So what will you do next? You will give the patient oxygen therapy. So in your hospital, you have device the interface to give the patient oxygen, right? So when you give the oxygen, this can improve saturation, okay? However, some patients have more severe disease, like for example, like a total obstructions or pulmonary fibrosis, and even heart failure patient. I saw in your ICU you have some patient with heart failure and poor fluid accumulate in the lung region, and this can cause lung collapse. Okay, so if the lung collapse, we can see that the ventilation reduce or vanish, and saturation dramatically decrease. So we call this shock. So shock means that no ventilation, but just have perfusion. Okay, and because you have oxygen therapy, right? So if you give the patient oxygen therapy, do you think it works on this kind of situation? If you give oxygen therapy, but the lungs are collapsed. So if you just give oxygen therapy, it doesn't work. Okay, so we call this refractory hypoxia. Refractory means that the patient has poor response to oxygen therapy. So even you give the patient 100% of oxygen by non-rebreathing mask, the saturation is still low. Okay, so if you see these things in your ICU or in your hospital, you need to think about this issue. This shock happen. Okay, so how can we deal with this problem? We need positive pressure. So we need positive pressure to expand our alveoli first. Okay, not just expand our alveoli to solve this obstruction over here or some poor diffusion. We can use positive pressure to redistribute the fluid, okay, or cause the fluid return back to the capillary, okay, to release the pulmonary edema. Okay, so we use the positive pressure to expand the alveoli to restore ventilation. So now the ventilation and perfusion is matching, okay, and we concurrently give the patient oxygen therapy to improve saturation. So that's why this is our today's topic. We like to use the positive pressures on these severe cases. Okay, so we focus on the first part, non-invasive mechanical ventilation, or called NIV. So the first is indication of NIV, and this is some criteria of that. So you can see that the respiratory rate increase about 25, means that the patient maybe have some problem to increase vocal breathing. And we can look at the third part, moderate to severe dyspnea with accessory muscle, neck muscle using, and also some irregular breathing pattern. Okay, so it means that the patient increased vocal rate is one of the indications to use an IV. Okay, to use positive pressure to support the patient. And the other thing is the gas exchange, acidosis, pH decrease, and CO2 increase. So it's like a hypercapnic respiratory failure, or we call this impending hypercapnic respiratory failure. Okay, so maybe just meet 1 to 2 criteria, and this is your indication to use an IV. Okay, and another criteria is that it depends on disease. For example, if the patient like COPD, COPD, right, chronic obstructive pulmonary disease. So some patient has COPD exacerbation and cause CO2 retention, cause hypercapnic respiratory failure. And or some disease cause mild to moderate hypoxic respiratory failure. Hypoxic means that they just problem with oxygenation. And hypercapnic means that they have a problem with CO2 carbon dioxide with ventilation. And some patients mixed type have ventilation problem, have oxygenation problems. And if these things happen in your hospital, in your ICU, you need to use BiPAP because now the patient has this CO2 problem, and mixed type also have CO2 problem, and oxygenated problem can also be treated by BiPAP. Okay, but if the patient just has mild hypoxic respiratory failure, just mild, or sleep problem, obstructive sleep apnea, or we call OSA or SA, and or acute heart failure without these important things, without CO2 retention, you can use CPAP as well. Okay, and later I will talk about what is BiPAP, what is CPAP, and this part you just need to focus on. If the patient have ventilation problem, you need to consider BiPAP first. If the patient just have oxygenation problem without ventilation problem, you can use CPAP or BiPAP. Okay, and contraindication of use NIV include this disease, this condition relate to more severe cases, and means that this patient required to use endotracheal tube intubation, require invasive mechanical ventilation. So like a respiratory or cardiac arrest, hemodynamic instability, and or multiple organ failure. And the below things show that because NIV will need a mask to cover nose and mouth of the patient. Okay, so if the patient have anatomy abnormality, like some fistula or some facial trauma, and this is another contraindication to wear the mask. Okay, and the relative contraindication includes a lot of secretions or obesity or just nasopharyngeal problem. And relative contraindication means that the patient can still use BiPAP, but you need to have more intensive care about this patient. For example, if the patient have a lot of sputum, you need to suction often. Okay, and extreme obesity, sometimes you need more higher than normal pressure to ventilate the patient. Okay, and the following is that how to use an IV on your patient. So the first is to select the size of mask. And the proper size is that the mask should be covered the bridge, from the bridge of nose to the below is a lower chin, below the lower chin. Okay, so usually we have a small, medium, and large size of mask. And even you don't have this skill, you can just take different size of mask and go to the bedside and to measure the face, the dance of the patient. And the next step is connection. So the left part, this part is the ventilator and connect with a single circuit. And I magnify this part. Okay, so this part is the mask over here, and connect to this one. This is called oxygen adapter. And this adapter should be connected with a tube, with one tube over here. And this is the oxygen tube and connect to the wall, the flow meter, oxygen or oxygen cylinder. Okay. So oxygen is added in from this port. Okay. And on the mask we have the respiratory, or we call lip port on the top. So the patient breathe in, the positive pressure delivered by this part to the mask, and the patient breathe out from the port around the mask. Okay, so that's why the ventilator just has single circle over here. And another thing is safety valve over here. Safety valve just for safe. So during normal condition, this valve is closed. But if this machine, the BiPAP machine or CPAP machine is not working, is shut down. Okay, this valve will open to let the patient breathe room air from this port. So this just prevents suffocation. Okay. And later in our workshop, we have to stop and we'll let you to connect the device. Okay, and next I will talk about the mode. The first is the CPAP, the other is BiPAP mode. And in CPAP mode, you just set a pressure, okay? Just set a pressure around here, and the patient can breathe spontaneously under this pressure. So you just need to set we call this CPAP level over here. So for example, if we set the CPAP level around 5 centimeter water, it means that during aspiration, the alveoli can get 5 centimeter water of pressure. Okay? And during inspiration, the patient can still get the same pressure, 5 centimeter water. So that's why we call continuously. Okay, so during aspiration and inspiration, you just deliver one pressure. Okay. And next is BiPAP. BiPAP, this bi means that it's a bilevel. So you can imagine that it delivers 2 levels of pressure, not just 1 level. Okay. So during BiPAP, the same thing. The first is that you need to set this is called EPAP, expiratory positive airway pressure. And this pressure is similar to CPAP level. Okay, similar things. And second, because this is BiPAP, you need to set another pressure, another high pressure, we call IPAP, inspiratory positive airway pressure. So you need to set 2 levels of pressure. Okay? And you can see the difference between these 2 levels. We call this delta pressure, IPAP minus EPAP. Okay, it's delta pressure. So I showed in this green, dark green color, dark green rectangle over here. So for example, if I set BiPAP 18 centimeter water, EPAP I set 5, it means that during aspiration, the patient can get 5 centimeter water of pressure during expiratory phase. And during inspiratory phase, the patient can get 18 centimeter water of pressures during inspiration. Okay. So you can see that this is a dynamic change. Alveoli can expand under inspiratory phase and decrease the size under expiratory phase. So the size of alveoli can change. And this change have one benefit. One major benefit is that they can deliver ventilation to the patient. Okay? So under BiPAP, they have ventilation, so they can wash out carbon dioxide compared to the CPAP. And another thing is the trigger. And trigger means that from above is a pressure trigger and flow trigger. And these 2, we can call them patient's trigger. Okay? So it means that the ventilator senses the pressure decrease because when the patient trying to breathe in, the pressure will decrease in ventilator circuit. And the ventilator can sense these things. So if the ventilator senses the pressure decrease 1 to 2 centimeter water, and the ventilator will deliver a breath to the patient. A breath means that the pressure will shift from EPAP to IPAP. Okay? And another thing is that the flow trigger, you can set 2 to 3 liters per minute. It means that when the ventilator senses the flow decrease 2 to 3 liters per minute in ventilator circuit, it means that maybe the patient trying to breathe in. Okay, and after that, the ventilator will give a tidal breath to the patient. Okay. So these 2, we call this a patient's trigger. The ventilator can sense the trigger from the patient. So later I will use this one, the yellow triangle, to symbolize patient's trigger. And another thing is that if the patient is apnea without any spontaneous breath, you can still use BiPAP. Okay, and BiPAP have another way to trigger is called time trigger according to your respiratory rate setting. So it means that if your respiratory rate set 12 breaths per minute, in 1 minute the ventilator can deliver 12 breaths of the pressure from EPAP to IPAP according to the time interval. Okay, so in our mechanical ventilation, every mode, some mode just have time trigger, some mode is combine these two, time trigger and patient trigger, and some modes is just patient trigger. Okay. But during our workshop, you will see BiPAP ventilator and CPAP ventilator. But some ventilator, commercial ventilator, they use scale, not just use the specific pressure or specific flow value. So for example, like BiPAP, you will see later, they use the scale 1 to 5. So maybe 1 is high sensitivity to sense the patient's trigger, and 5 is low sensitivity to sense the patient's trigger. Different devices have different unit, okay, different scale. And if you look at this ventilator settings, it's like this. It's the scale. It's not the specific value. You can start from the median value. So maybe 1 to 5, you can start from 3 and increase or decrease according to the patients. Okay, so in BiPAP, they have these 3 modes: S mode, ST mode, and T mode. And I focus on T mode first. T mode means that you deliver EPAP, right? And during inspirations, it shifts to IPAP, okay? But T means time. So every breath is time trigger only, okay? It is independent of patient's trigger. So this is called T mode, or we call time mode. And another is ST mode. ST mode means that the pressure can still shift from EPAP to IPAP, but this pressure, this dark gray color, this area can be delivered by time or patient's trigger over here. So this combines two. So we call this ST mode, spontaneous with time mode. And another is S mode. S mode means that all of the trigger are by patient only. So this is called spontaneous mode. So as I summarize here, in T mode, only time trigger, independent of patient spontaneous breathing. In ST mode, is combined. Sense patient's trigger, also triggered by time. And another is S mode. S mode just sense patient's trigger. So you can imagine that if the patient is frequently apnea, you cannot use which mode? Which mode you? If the patient frequently have apnea, which mode you cannot use? S mode, right? Because it requires to sense patient's trigger, right? Okay, so usually for us, because sometimes we don't know the breathing pattern of the patient, so we usually, in our hospital, we usually set ST mode. Okay, we seldomly use S mode. Okay, so this is initial setting, but I need to emphasize that this initial setting is not the fixed value. Okay, it's just a range or acceptable value. Okay, so if you like to use the CPAP, you may start from 5 to 10, or some textbook write 8 to 12 centimeter water. Okay, and I already told you that because the O2 flow is added in to the breathing circuit, so the O2 flow. The maxima FiO2 fraction of inspired oxygen is quite low. It's less than 50%. Okay, because in BiPAP we just add in O2, and in BiPAP or CPAP the same. And in BiPAP the O2 is the same because we add in O2 flow into the ventilator circuit. So the maxima O2 fraction is low, is just 50%. Okay, so if the patient required to use O2 higher than this value, maybe you need to consider maybe the patient required to intubate. Okay, and in BiPAP, you need to set IPAP, and this IPAP is around 20 to 25. The maximum level is 20 to 25 centimeter water because you need to use mask to cover the nose and mouth of the patient. And some positive pressure can go into the lung, but some positive pressure can go into the esophagus, cause gastric distension. So we need to limit the pressure around 20 to 25. Okay, this is the maximum value. And EPAP should be more than 4 centimeter water to wash out the carbon dioxide within the ventilator circuit. And the delta pressure, you can start from 8 to 12. Okay? And the backup rate in T mode or ST mode, you can set the respiratory rate around like a normal people, 12 to 20. And we usually start from 12, 14, or 16. Okay? And the next thing is adjust the ventilator setting. So if you use BiPAP, okay, so now you imagine that the patient used the BiPAP, but you see that the patient have poor ventilation, okay, CO2 still high. Which parameter will you adjust? I give you a basic concept for you to remember is that if you like to wash out carbon dioxide, you need ventilation, right? And from the figure, which part is ventilation? Is a light green color or dark green color? Light green is just like a CPAP, deliver the same level of pressure, and this pressure is low. And dark green means that the alveoli is from aspiration is small size, inspiration is pen, aspiration decrease size. So this dark green have ventilation. So if we like to wash out carbon dioxide, we need to increase area of this dark green color. Okay, and which parameter can we adjust? The first, increase IPAP level. So when we increase IPAP level, we can increase this delta pressure, IPAP minus EPAP. Okay, so the area under this rectangle increase the size. Okay, and another thing is that in T mode or ST mode, another way is that you can keep IPAP constant and you increase respiratory rate. But this respiratory rate you can just set in T mode or ST mode. Okay, so you can increase the number of this green triangle, dark green triangle, and this another way to increase ventilation. Okay, so just remember the dark green part. You need to increase the size of that. You can increase IPAP, increase the respiratory rate. And if the patient have poor oxygenation when you use the CPAP. Because if the patient have ventilation problem, you need to use BiPAP instead of CPAP. So I just talk about BiPAP. But if the patient have oxygenated problem, you can use either CPAP or BiPAP. Okay, so if the patient have poor oxygenation, first you can increase O2 flow from flow meter. Okay, so maybe the patient just use 3, you can increase to 5, to 10, to 12, and the maximum level is 15. And the maximum oxygen you can deliver maybe is just 50%. Okay? And another thing is that if you increase the O2 flow, the saturation is still low. You need to think about refractory hypoxia. Maybe the lung is collapsed. Okay? So the next step for you is to increase the CPAP level because in CPAP you just have this parameter you can set. So increase the CPAP level to expand alveoli, to expand collapse alveoli, to improve the shunt, to let oxygen go inside. And another thing is if the patient use BiPAP, have poor oxygenation, the same thing. The first step, you can increase oxygen flow from the flow meter. Okay? And the second thing is the same because I told you that EPAP is similar to the CPAP level. So you can increase the EPAP level to expand alveoli. But if you just increase EPAP level, which problem will occur if you just increase EPAP level? gastric distension. If the total pressure is below 20 to 25, it's hard to cause gastric distension. So we just assume that all the high pressure below 20 to 25. Okay, so I want you to look at the figure. Decreased what? Ventilation, good. So you will see that because the ventilation is this dark green color, right? But when I increase EPAP level, I increase the light green color, this area. It decreased, but I keep the EPAP at the same level. It decreased the ventilation. Okay. So if the patient just have oxygenating problem and you just increase the EPAP, sometimes this can decrease the ventilation, and sometimes this can cause another problem. CO2 start to retain. Okay. So if you like to keep the constant ventilation, usually we need to increase both IPAP and EPAP simultaneously in order to keep this area, this ventilation constant. Okay. So this is much tricky things in BiPAP mode. So you need to consider these things: ventilation and oxygenation, the interaction between these two. Okay, so this is just a summary. If you find a problem, ventilator problem or oxygenating problem, the first things you need to do is to do chest care, suction, maybe you need to drop inhalation, maybe just leakage. And you need to reverse this condition first. Maybe you don't need to adjust any parameter, just reverse above condition. And if the ventilation is still poor, you can increase IPAP level or increase respiratory rate. If the patient have poor oxygenation, increase O2 flow or CPAP or EPAP level in BiPAP mode. But you need to think about that. If you just increase the EPAP level, sometimes you need to increase IPAP a little bit to keep the delta pressure, IPAP minus EPAP keep constant. Okay, so we can see these figures C and D. We just see these two. This means that the IPAP is 15, EPAP is 5. So we can get this ventilation. The tidal volume is around here. Okay, but if we just increase the EPAP, we just increase the EPAP from 5 to 10, over here. But if we keep the IPAP constant at 15, the tidal volume will decrease. Okay, decrease ventilation. Okay. And other things is care about the BiPAP or CPAP patient. And the common question is discomfort or we call pressure sore on the face. Okay, so you need to loosen the strap. We can accept some leakage. Okay, so not wear the mask too tight. Okay, we can accept some leakage. So just loosen the strap or change. Sometimes we will shift to another mask. Maybe the patient uses full face mask and we can shift to another one, maybe just nasal one. Okay. And another common side effects to use CPAP or BiPAP is dryness. So later in our workshop, we will see that we will add humidification. Okay, by this humidify. And another thing is gastric distension. So we need to limit the pressure below IPAP, below 20 to 25 centimeter water. And also sometimes we will use NG tube, nasogastric tube, to decompress the pressure within the stomach. Okay, and the final part about non-invasive one is weaning of an IV. So we just decrease the pressure, decrease the O2 flow. And in our hospital, we call try-off. A try-off means that we remove the mask. Okay. So for example, like this, maybe the condition is already solved. We can just remove the mask for 2 hours, twice a day. And then next day, the patient is stable when we removing the mask. Next day we can extend. We extend the try-off period. Extend to 4 hours, 6 hours, 12 hours, and let the patient overnight. Okay. And after overnight, usually we follow arterial blood gas under this part, overnight this part. So when we remove the mask, let the patient overnight and follow arterial blood gas and to see oxygenation and ventilation is stable or not. Okay, and if the patient is stable, we can discontinue. But if the patient still have oxygenation or ventilation problem, we need to restart NIV. Okay, so this is a weaning process of NIV. Okay, and next part I will talk about invasive mechanical ventilation. And but this part.
Yeah, I think everyone will. You heard a lot about inspiration, acceleration, all these numbers. But later we will try to use the machine to let you practice. Okay.